Hello, this slide series is going to take you through the idea of how to identify risk for pressure injuries and how to prevent them. We will cover mostly the patient in an acute care setting. However, I did include some information for those of you that are working in long-term care because obviously pressure injuries occur in both settings. This is Joyce Black and I will be the presenter for this material. In this hour that we spend together, we're going to try to meet these objectives to identify the common risk factors that lead to the development of pressure injury or pressure ulcers. You may have also heard these things called bed sores, decubitus ulcers, decubes. They've been around for a while and they've had all sorts of names. The current name of the problem is pressure injury. You may be looking at documentation that has not been changed to the updated terms. So if you're seeing the word ulcer, pressure ulcer in the documentation system, that is referring to the same condition that we're going to be talking about. So what we're going to look at is a product called the Braden scale to identify areas of risk, and then we're going to look at nursing interventions that are targeted to those areas of risk. We will also look very briefly at one condition that is not on the Braden scale per se, and several other conditions that equally increase risk, but we really don't have a good set of interventions for them today. So I'll tell you when we get to those. And then, as I said, we're going to look at the nursing interventions that are targeted to the areas of risk as identified in the Braden scale. The idea of that is that you'll be able to individualize the interventions to the area of risk for your patient. Pressure injuries, by definition, are areas of localized damage. That would be in contrast to other skin diseases that you would see all over the body, like psoriasis. And the skin can be involved, or sometimes the underlying tissue can be involved. So the underlying soft tissue would be the fat, the muscle. These injuries can reach the level of bone. Usually they're found on the bony prominences. So if you're sitting and listening to this now, you can palpate your wrist bone, pretty easily found. There's not a lot of fat covering it, so it's quite prominent bone. However, what we're really concerned about are the bony prominences that the patient is lying on in bed. So what we're thinking about, starting at the top of the body, would be the occiput, the shoulders, the sacrum and coccyx in the lower part of the spine, the heels. Then when the patient is turned on the side, it would be the ankles and the sides of the knees and the shoulders that would be at risk. Pressure injuries can also form underneath medical devices, such as oxygen tubing and devices commonly seen in critical care. If you're in a critical care rotation now, you're seeing lots of devices in use, and each of those devices that's resting on the lip or the skin can lead to an ulceration. So the wound can be visible as an open ulcer, or the skin can remain intact initially but still show signs of pressure injury. They can be painful to the patient if they're able to report pain. The cause of pressure injuries is pressure. So the pressure can either be intense or prolonged, or a combination of the two. I can't give you a number of what intense is. I can't give you a time of how long prolonged is, but I think you can easily see that it depends a lot on the surface the person is sitting on. So if you're at a football game and you forgot to bring your chair cushion, your seat pad, you're not going to sit there very long on those wooden or metal bleachers. You're going to get sore, particularly on the ischial tuberosities, because obviously you have to sit up straight, right? But think about that in contrast to sitting out in the lake. You could sit there for hours without pressure having anything to do with your bony prominences because the pressure's been dispersed throughout the body. So when we add shear to the mix, shear is a pulling, stretching phenomenon. We see that particularly in patients with the head of the bed up, where they slide down in bed and then we have to boost them back up in bed. So that's the risk factor that really drives these patients' pressure injury risk. Now, if you've been in clinical practice for a while, you may have noticed that not everybody gets a pressure injury that you think maybe they should have. So you've got two people of equal risk. They have the same diseases, they have the same reason for admission, and yet one person gets a pressure injury and one doesn't. So we think about the other side of the coin, if you will, which is the tolerance of soft tissue for pressure. So we look at these factors. How wet is the skin? How well is the blood getting to the skin? How well is the blood nourishing the patient? Is there already injury to the skin? Has there already been damage to the skin that we can see? And has there been a previous pressure injury that is healed, but healed with scar tissue? And that scar tissue does not tolerate pressure or shear at all. I'm a member of the National Pressure Injury Advisory Panel, which is a U.S. group of multidisciplinary experts in the area of pressure injury prevention. One of the things our group does is try to keep track of the national numbers or the seriousness or the significance of these wounds. So the next couple slides, I just want to try to convince you, if you're not already convinced, that this is a pretty significant problem. So what we know statistically is that there's a lot of cases in a lot of settings with patients that have pressure injuries. They are seen in neonates, they are seen in adults, they are seen in teenagers, they're seen in the elderly. And the prevalence, which means how many cases are there today. So if I just went around the world and asked how many pressure injuries do you have today, I'd get a pretty high number. I'd get 72.5%, depending on who you read and of course who you ask. Now the incidence, that's the number of new cases. So how many people came into your facility with intact skin but developed a pressure injury while they were in your facility? You can see that's at 6.3%. So each time there's a new case, it gets put into our prevalence bucket because now it's an existing case. So that's why the number is so much higher. So who's at risk? Patients who are paralyzed. So those are folks with spinal cord injury or stroke. Patients who are critically ill because they've got lots and lots of significant issues with perfusion and oxygenation, and sometimes an inability to be repositioned. Those who are dying, they are seen in children and neonates, particularly from medical devices. And we're seeing lots more pressure injuries from medical devices. So we're going to add that to our list of things that we want to take precautions for. Well, we also know that pressure injuries are pretty expensive, and in the federal budget, when people have pressure injuries, it adds about $11.6 billion to what is spent by Medicare and Medicaid services in the U.S. This does not include what's spent by other insurers or how many people have no insurance and still require care. In 2016, the most recent estimate of cost was done by Bill Padula, and he estimated nearly $27 billion spent on pressure injury treatment. So if we could knock these numbers down, we could save ourselves some pretty significant dollars. Now, on top of the direct money expenditure, there is increased morbidity and mortality from these problems. Patients stay in the hospital longer. They have to have procedures like debridements. Nurses have to change dressings. The wound hurts. The wound smells, which may limit their ability to socialize once they get out of the hospital. And all of that together increases the patient's stress, anxiety, and can lead to depression. So these are significant problems and should not be underestimated at all. If you happen to be on a rotation now in long-term care or currently work in long-term care, you probably have been made aware of the fact that the Department of Health sends out nursing home inspectors to inspect the quality of care in long-term care. That process started in 1987, and at that point in time, it was decided that pressure injuries should not be occurring as often as they were, and that many of them are avoidable. If we do the right things, the skin should stay intact. And so back in 87, the government decided that they were going to start tracking on pressure injuries and many other things. And today it still is true. If a patient develops a pressure injury in long-term care, the facility can be penalized for the development of that wound. So the way it's determined is the health department in each state sends out nursing home inspectors to look at a group of patients, either routinely or because someone called them to come out. If they find patients or residents in long-term care with pressure injuries and the facility determines that it should not have happened, then they're called unavoidable. And there's actually a number that goes with the citation. It's called an F314 tag. I don't know if you've ever heard that term before, but that's what it refers to. And then on top of that, the number of patients that develop pressure injuries is published on a website that the federal government puts together called Nursing Home Compare. And so a family looking to place a patient in the facility could look to see how many patients have problems with pressure injuries and a number of other things. Well, the same regulations that were true in long-term care really didn't come into play in hospitals until 2008. And in 2008, again, the federal government tried to cut the budget down for what it was spending on conditions that occurred in the hospital. And they also made a determination that pressure injuries are avoidable in almost all cases. And instead of tacking on something called an F314 tag, what happened instead, and is still true today, is that if a pressure injury happens during hospitalization, the hospital cannot be reimbursed for any of the care necessary to treat the patient with the wound. It can be lots of things. Can be support services, might be trips to the operating room for debridement, closure of the wound, lots of dressings, a whole number of things are not, the hospital's not going to get reimbursed for that. So much like long-term care, there's a hospital compare that you can dial up the hospital and see how it's doing on pressure injury numbers and other things too, falls and medication errors and things like that. But this makes this problem of pressure injuries pretty obvious to the general public who may be looking at coming to one of your facilities. Because many people feel that pressure injuries are avoidable, families and or the patient, if still living, can sue the healthcare provider for malpractice. And the family or the patient at that point obviously feels that this pressure injury that developed was completely unexpected and due to an error on somebody's part on the healthcare team. And so the family seeks an attorney who files a lawsuit on their behalf. Today, lawsuits related to pressure injuries are the second most common reason to sue a provider. Wrongful death is the most common reason to sue. About 17,000 cases filed a year. The average verdict, so that would be at trial, is somewhere around $1 million. There are some lower than that, and there are some many, many million more than that. The average settlement is right around $250,000, and that's given to the family or the patient if the patient is still alive. Well, sometimes pressure injuries lead to fatal illness, particularly sepsis. An old estimate was that about 60,000 people died a year of pressure injuries, and they died from sepsis from the open wound. The pressure injury can also require pretty aggressive treatment for it. So this contributes to what we call morbidity, or what happened to the patient. They can have a leg amputated for a pressure injury on the heel. They can require a diverting colostomy if the patient has an extensive wound on the sacrum and it's constantly contaminated with fecal matter. The surgeons may decide to pull the intestine out through the abdominal wall, a colostomy, in order to stop the fecal exposure in the wound and try to get it to heal. Plastic surgeons may be used to close the wound with a flap, which means they're moving tissue from one place to another. Even when there's no aggressive surgery done, these wounds take a long time to heal. So if the wound is allowed to heal secondarily, that is with scar tissue, they take sometimes up to a year to heal. And the scars that remain are permanent. They can be painful. They can re-ulcerate. So pretty significant problem is the problem of pressure injury. Well, hopefully I convinced you of the seriousness of pressure injury. So let's dig in to figure out where we're going to go with this problem. What's the nurse's role in this problem? And nurses have a substantial role in the prevention of pressure injuries. We all are part of this team, and certainly other members of the healthcare team play a part, but I don't think there's a bigger part played by anyone than the nurse. So here's basically where we're going. We're going to dig into a little bit of detail here. We're going to make sure that we understand where the risk is coming from in the development of this patient. So we're going to try to catch problems early. We're going to do that by inspecting the skin. We have to recognize that risk changes over time. So the way you see a patient today may not be at all the condition of the patient tomorrow. So don't think that the risk factors that you looked at yesterday apply to today. I think the corollary would be you certainly wouldn't write down yesterday's vital signs to describe what's happening today. So that's the same idea. The risk can change over time, can get less, can get more. And there are some risk factors that are not even in a device called the Braden scale, which we're going to talk about. And for those patients, we need to do some critical thinking and try to go beyond the Braden scale. Going to do a lot of interventions to reduce risk, including the bed the patient's on, called the support surface. We're going to turn and reposition the patient. Obviously, keep the skin clean and dry. Make sure they're adequately nourished. Make sure the heels are protected from injury. And we're often going to use prophylactic dressings. Now, this was the 30,000-foot look. We're going to drill down into quite a bit more detail as we head through this problem. Well, I want to introduce a new idea to you on the pressure injury problem, and that is the role of screening. Screening is a way to identify risk as early as possible. So I want you to think about you're getting a phone call about a new admission, a new transfer to your facility or to your unit, and you identify from the phone call that this is a patient who's extremely immobile due to being in a coma or coming directly out of surgery or is paralyzed or is unable to move for some reason, or they're terribly inactive in that this is a quadriplegic who is coming into your facility, or extremely malnourished due to lots and lots of other conditions. Well, those patients are at risk, and we know it now. We really don't need to do a formal evaluation of risk. We pretty much know the story. So think about, can we upgrade the mattress by applying an overlay right away before that patient even arrives in order to reduce risk the moment they get into the facility and land in one of your beds? Let's start with skin inspection. Skin inspection is the assessment, the visual assessment, and sometimes palpation of all the skin. And the nurse does it on every shift if you're in acute care. If you're in long-term care, the nurse's aides should be helping you with this by seeing all the skin in the patients that they help get dressed or turn or clean in their beds. So the skin is assessed on everybody every day. It just depends on who is doing it. So how do you do that? Well, you have to be able to see the skin. So that means that clothing and gowns and socks and shoes, all of that comes off. So it's probably easiest to do when the patient's at bed rest and all they have on is a gown, or they're being bathed or showered or cleaned up of incontinence. So take advantage of those episodes in care that you can see all the skin. If you're caring for a patient who's in bed, I want you to turn the patient to the side and get them into a position that you can see the sacrum and coccyx. That means that if you can hold them with your left hand and you can separate the buttocks cheeks and look at the sacrum and coccyx, well, more power to you. It's likely to be needing two people to do that. So grab your CNA or classmate or someone to help hold the patient over so that you can see the sacrum, the coccyx, that you can pull the hair apart and look at the occiput. You can look at the shoulders and take the blankets down so you can look at the heels. You also are going to want to move or remove the medical devices. So if this patient has on elastic stockings or has on sequential devices for DVT prophylaxis, they have to come off. You can't see through them, so plan on taking them off. Now, some of these devices are hard to get off or hard to hold the patient still while you're doing that. So here's another opportunity to use somebody else to help you. If the patient's supine in the bed and cannot be turned, for example, they have a broken hip, then use a mirror to see the heel, because you can't see the heel very easily unless you put your head in the bed, and try to look backwards. And I think one of the easiest ways to look at the skin is when the patient gets out of bed. So if this is a patient who's ambulating with physical therapy, plan to go in the room when physical therapy is getting the patient up at the edge of the bed and get a good look at their backside while they're up, because there's going to be a couple of moments there while they're waiting for the patient to not be dizzy and to be able to move safely. That's a great time for you to look at all the skin. You can see in the photograph that was a patient who developed a pressure injury from oxygen tubing behind the ear, and it was found during a shift assessment on the patient. We know that inspecting and assessing skin in darkly pigmented patients is more difficult because the redness that we typically see indicating areas of concern are not visible because of the dark pigmentation of the skin. There's no reason to think that people with darkly pigmented skin have a different response to pressure. It's just we can't see it as easily. So a couple techniques to help you a little bit. One is to moisten the skin. The skin of darkly pigmented patients tends to be quite dry, and when it's very dry on the outer layer, it occludes you from seeing the deeper layers. All you need is tap water on a washcloth. You don't have to soak them down, but also be careful you don't rub the skin, because you don't want to stimulate a red response that you mistake for a stage 1. You're going to ask about pain in high-risk areas. Do your heels hurt? Does your sacrum hurt? Does your head hurt? Do your shoulders hurt? Because if you're not able to see it, the patient will still have a sensation of ischemia in that tissue. Palpating, which is what's shown in the photograph on the slide, when the skin is injured from pressure, it becomes edematous, and you can feel that edema. In the heels, it feels boggy, and when you push down, they're real spongy. In other parts of the body, it may not be boggy, it may actually be harder. And so when you palpate surrounding skin, you're going to find the normal palpation, and then you're going to come across this bony area, and it's going to be quite hard in the skin, obviously not to the bone. Then you want to compare the skin of the color to surrounding skin. So is there been a change in the color that you can see by looking at surrounding skin? Skin assessment in bariatric patients is harder because you can't do it alone. You've got to have adequate help. So be sure you get people to help you use the lifting devices if you can. Sometimes they occlude you from seeing the skin, and so we have to actually turn them manually. You can see the picture on the right of the nurse trying to move this bariatric patient over so we can check the back of her buttocks and her head and her heels while she's in bed. Recognize there's potential for injury to your staff, so be careful that you have good body mechanics. The goal of this is to see the skin fold to the bottom of the fold. So look at the picture on the left. We're not even close yet to the bottom of the skin fold. It's going to take lots of hands to pull that skin apart to make sure that there's no injury at the bottom of the fold. So what might you find? Well, these are some common things that you might find. You might find stage 1s, which you can see on the knees of the man in the bed, the first picture there that you come to. That's because the knees are pressing together, and that when you palpate it, it won't blanch. You might find deep tissue injury, which is the picture at the bottom on the right, which is an area of purple or maroon discolored tissue. You might find incontinence-associated dermatitis, which is the area of erythema up on the top. So what do you do when you find these things? Well, unless you are trained in skin and wound care, you probably want somebody else to take a look at this. So I advise you to find the nurse or another person who's skilled at skin and wound care, or call the wound nurse and have him or her help you to properly label it. You want to initiate a plan of care. So if you found the stage 1 between the knees, don't put the patient back in that position. Put the patient in a different position or put a pillow between his knees so you take the pressure off. If you find IAD, you're going to want to put a barrier cream on that to try to protect it from further damage. If you find deep tissue pressure injury, you're going to want to get that patient on the side to make sure you're taking pressure off of the sacrum. Then be sure you document those skin problems accurately so that it's clear when that condition was found. Nursing has a device called the Braden Risk Assessment Scale. Barbara Braden invented this a number of years ago, and it's actually become the gold standard in identifying patients at risk. The scale, the complete scale, is there on the slide for you. I'm sure that most of you are working with electronic medical records, and it's embedded in the electronic medical record. But the scale has 6 parts. One is the sensory perceptual scale. So can the patient feel and respond to pain? How exposed are they to moisture? How active? How mobile? How well nourished? And whether they're exposed to friction or shear. We're going to dig into these subscales in a little bit, so I don't want to spend the time now doing it, except to tell you that, as you can see on the figure in the slide, every scale has 1 to 4 points except friction and shear, which has 3. That makes the total number of points 23. And if a person scored a 23, they would be up and moving and active and completely aware and eating well, continent of urine and stool. And so they'd be at very little risk for pressure injuries. When you examine the patient using this scale, I want you to score them the way you see them now. I don't want you to think about the way they were yesterday or the way you think they might be tomorrow. So it has to be current to the way you're seeing it today or your shift. And yes, the score will change because the patient's risk will change. So these are the subscales broken down so you can read them. I realize that what you may be looking at on the EMR is simply the heading. So it will say sensory perception completely limited all the way up to no impairment. And it would be good for you to understand what each of the little boxes means inside of there. So let's just look across. A completely limited patient is completely unresponsive, makes no movement to any painful stimuli. So this is a patient who's comatose, anesthetized, sedated. And then you can see as you go up the scale, the patient has more and more sensation. So let's look at 2. Number 2 says the patient responds only to painful stimuli, can only respond by moaning when you do something painful to them to elicit that response, or they have a sensory impairment over half of the body. So a patient who's a paraplegic would fit in there. A patient who's had a stroke and a hemiplegic would fit in there. Slightly limited is the patient who has more cognitive ability now, but doesn't feel pain in 1 or 2 extremities. So if you're taking care of a patient with a fractured hip or a total knee replacement, that patient would be slightly limited. And then the patient with no impairment doesn't have any disability of sensation or perfusions or perception. So they can tell you it's time to turn. They can sense it's time to turn. Looking at the one on moisture, I think the gradation is a little more obvious. Is the patient's skin totally wet all the time of urine or diarrhea? Every time you go in to see the patient, they are wet. You've got to change them almost every time you come in to see them, all the way up to the patient's rarely moist. So this is a patient with routine linen changes. The activity and mobility subscales are there in front of you, and even though they sound like they're the same, here's the easiest way to see the split. The activity is a person who gets out of bed, and to what degree do they get out of bed? Do they get out of bed to a chair, or do they get out of bed to walk? And the mobility is the person who remains in bed and turns side to side in bed or moves themselves in bed. So when you look at the breakdown of scores, you can see that the person who's bedfast is confined to bed, but that doesn't mean they can't move in bed. So just because you'd score a 1 in activity wouldn't automatically mean that you'd score a 1 in mobility. You could turn yourself in bed, but perhaps are simply confined to bed. And then as you move up to a level called chair fast, that seems to be a common one, particularly for the elderly who are confined to wheelchairs or ambulate or mobilized by wheelchair. And so it depends on how much they can walk on their own. So if this is a person who simply gets pivoted and sat in a wheelchair, that would be scored a 2, where the patient who walks some but gets up a bit during the day but tends to sit in a chair, like a recliner chair, would be number 3. And then the person scored number 4 would be the person who gets out of bed, walks around a bit, and walks enough of a distance where it's at least, every couple of hours that they're getting up. Now, mobility, as I said, is the ability of the person to move on their own in bed. And so if you look at the wording on these things, is this a person who makes no movement whatsoever? So the way you left them 2 hours ago is exactly how you find them now, versus the person who moves a bit, moves a leg, moves an arm, or the person who can, like I presume you, at night can turn yourself over in bed onto the side. So that's the activity mobility subscale. The last 2 to look at are the nutrition and friction and shear. The nutrition is the patient's usual food intake, and you can see we've got a combination here of things that are eaten orally and then tube fed or fed intravenously. So you can see the difference. The person who's at a level 1 never eats a complete meal, rarely eats any more than a third of their tray, doesn't consume any supplements, or has been NPO or on clear liquids for over 5 days. The inadequate person is eating a bit more, but not adequate protein, not adequate volume, only occasionally drinks their supplements. Then adequate nutrition patients are patients who eat a bit more or are tube fed, period. So even if they're tube fed and getting the correct volume of tube feeding, according to the nutritionist, they're still classified only as adequate. And part of that is that the majority of tube-fed patients cannot say to you, I'm hungrier than that. Can I have a little bit more? We're on a fixed rate for them. And then the patient who is excellent nutrition, sounds like you and me, right? Eats most of every meal, doesn't refuse, gets plenty of protein in their diet, does not even require supplements. So they're eating what they're being offered. Friction and shear is that phenomenon of sliding down in bed. And so this is the patient who has got the head of the bed markedly elevated and slides down, and you have to pull them back up. So when we look at the levels of scoring on Braden, the patient who's a problem for friction and shear is the person who is up in bed, slides down, or is spastic or confused. And it's sort of a constant battle to keep boosting them up in bed, and then they slide back down and you boost them back up. And the problem is the contact of the skin against the linen going back up and back down, because you're kind of sticking to the linen as you're going up and down. The person with potential problems moves a bit on their own, requires some assistance, so they're not constantly sliding down, but they're not as agitated as the first group. And then the person with no apparent problem, they move independently. They don't scoot across the bed. You can, when you put them in a chair, they remain erect in the chair. They remain in a good position in bed. So those are the 6 subscales of Braden, and we will be asking you clinically to evaluate your patient on all of those scales. It will be, I think, a good idea until you're comfortable with the wording of each that you have this with you so that you can see the actual text rather than going simply by the title of the section, which is generally what the EMR has. Sometimes you can hover over them to get the actual text, but that's really the only way you're going to be accurate for a while, is to have that text in front of you. There were a couple of formal revisions to the Braden scale made a while ago and then not too long ago. They both were focused predominantly on pediatrics. The first one added a subsection on perfusion and oxygenation. If you're in pediatrics, you should look at this subscale. And then the other one, the more recent one, added the use of medical devices to the Braden for children. So we're going to ask that you do a Braden scale on patients. You'll do it at the beginning of the shift. You might as well plan to do it with the other risk assessments, the DVT, the falls, the sepsis, all the other ones that you're doing anyway. Be thinking about what variations there might be in your patient. Maybe this patient had surgery on their leg and can't move the leg. Be sure you think about that. Do they have epidural analgesia? And maybe they're not sensing anything below where the epidural goes in, and so they're not aware that they've been sitting in one place. Or maybe when they try to turn, it just hurts so bad they don't turn adequately. Are they anxious or depressed and not taking in a normal amount of food that they would normally? Are you turning off tube feeding for medications and treatments for this patient? Is this patient sitting up in the chair for almost the entire day? And do you have lots of medical devices in place? So let's take a look at this case. A 92-year-old female who normally is in a long-term care facility due to dementia. She fell today and fractured her hip. She was admitted to your unit in Buck's traction and has pain and leg spasms anytime she's moved. She's oriented ×1, and she's 5 foot tall and weighs 85 pounds. So there's the subscales of Braden. Take a couple of minutes and see if you can figure them out without looking forward onto the next slide. Well, I'm not sure where you are in your program of study, so I didn't know if you'd had information on skin traction. So if you have, you can take a mental pause here for a second. So one of the things that was done to this lady was she was placed into something called Buck's traction. Buck's traction is a type of skin traction. That means there's not a pin placed into the bone to try to pull weight against that pin. But what it is, you can see a picture of it. It's usually a foam boot. Sometimes it's different products. There's a number of boots on the market, so don't expect just to see this example of one. But the idea is the leg is placed in that traction, and then a little bit of weight is placed on the end. You can see a string coming off the bottom of the boot, going through a pulley system at the foot of the bed, and then you can see a little orange and black bag hanging from the end. That's the weight that's being applied. It's not a lot of weight. It's usually around 5 pounds. It's not usually much, but the idea is that pulling on the leg will start to reduce the fracture, which means to pull the bones back into alignment. And once the bones are in better alignment, some of the spasms will stop. So while this boot is on, the patient really can't move that leg, nor will they want to. It hurts too bad. They can move the upper body. They could move the opposite leg. And depending on how agile they were and how much pain tolerance they had, they could probably lift their butt off of the bed. But I haven't seen a lot of people want to do that. Because of all of that, usually an indwelling urinary catheter is placed in the emergency room just to have the problem of trying to pass your water or urinate eliminated for these patients. One of the problems, though, we see with the Buck's boot system is that weight pulls the heel down into the bed, and the patients will complain of pain in the heel, and it's a very high-risk area for the development of pressure injury. All right, if you would pause the slides for just a second and not look forward onto the next slide where the answers are, and try to compute this lady's risk based on what you know about her case. Okay, let's see how you did compared to me. So we know the story of the patient. I put her cognitive perceptual score at a 3. And mainly it's because I don't know a lot about her level of dementia, and I don't know if her level of orientation right now is her routine level of orientation or if it's due to pain medication she got in the emergency room. But she's still able to report pain, and so I put it at a 3. You may have put it at a 2, and I don't know that that's right or wrong in this instance. Her moisture level I'd have put at a 2 because the catheter was placed in the ED. I don't know anything about her bowel habits in the nursing home. Hopefully I can find that out somehow in the record or from the nurses. She's certainly a 1 for activity and a 1 for mobility. She's absolutely confined to bed because of the traction. And because of the pain and the spasms, we know that she's not moving herself. I put her nutrition at a 2. The majority of it was based on the fact that she's only 85 pounds and she's 5 foot tall. She should be over 100 pounds at 5 foot. And then friction and shear, I put her at a 2 because the weights are going to pull her down in the bed. So that gives you a score of 11, which is a very high risk patient for pressure injury development. So what would this patient's nursing diagnosis and goal be? For the little lady that broke her hip, I think she is a risk for impaired skin and tissue integrity related to her immobility, her inactivity, her low body weight, and exposure to shear, and her Braden score of 11. The goals and outcomes will be that she will have intact skin and tissue integrity as evidenced by the skin remaining intact during this hospital stay. How am I going to know that? The skin will remain intact over areas of risk, and the reddened areas, if she develops any, will remain blanchable. There's a couple of ways to develop a plan of care for a patient based on the Braden score. One is to take a look at that total score and determine that you have a number of things you can do, and you can see the usual breakdown. So if a Braden score total is between 19 and 23, the patient is considered to be at low risk, but there's still a few things that you could do, all the way up to very high risk, which is the lady that we just talked about. The other way is to choose the interventions based on the level of risk and the type of risk, and that's the way we're going to go about it here. So I just gave you some ideas. We'll get into a little more detail. You could use a different support surface. You could put preventive dressings on the patient. You could put them on a turning schedule and those kinds of things. So the little lady in the picture, she's at risk of pressure injury. She's already got redness of the buttocks. She's actually got a small open wound up near the coccyx. So she'd be a high risk patient for us to be dealing with. So what I want to do in these next few slides is go through some interventions for you that are matched up to the level of risk that comes from the Braden subscales. So you can individualize the plan of care to the patient. So if this is a patient with a sensory or perceptual loss, you're going to want to check the skin under medical devices on each shift and make sure you've got adequate help to get them off and look at the skin. You can see the photograph is a patient who developed a full thickness pressure injury on the back of the scalp from a neck collar. And the problem was it was hard to get the collar off, so nobody could see that the wound was developing until there was blood on the bed. Turn the patient's head to the side when they're turned to the side to get the pressure off of the occiput. Be sure when you're doing that, you make sure the ear didn't get folded over underneath them. Float the heels from the bed. You can do this a couple of ways. You can put a pillow under the calf and let the heel hang off the end. Sometimes agitated patients will kick those pillows away. So at times you have to use heel offloading devices for the patient, like boots. They are a medical device, so be sure they come off a couple times a day to let you examine the skin. And we've already talked about the support surface, but this is the mattress that the patient is laying on. So if the patient is not moving or cannot be moved for some reason, we need to use a mattress or an overlay that reduces pressure. There's a couple around. One is called an alternating pressure overlay, where one column of air inflates and the other deflates, and so the patient kind of moves about. and the other is called a low air loss. And so ask your wound nurse or your manager or your instructor when and where we might use those for these patients. Well, since we were talking about heel pressure injuries, both in the patient, the little case we did, and in general, can you find 6 things wrong with this picture? Let me give you the story. I know you can see some now. This patient had a right total knee done yesterday. The right leg is the leg that is opposite of you. You're looking at the left leg now. Okay, go ahead. You got 3 or 4, don't you? All right, let me walk you through and see if you got what I got. So his leg is pressing, his left foot is pressing against the footboard. He needs to be pulled up to the head of the bed. It is possible to get pressure injuries on the bottom of the foot from resting on the footboard. Now, if you believe that the compression device that's on his foot is designed to reduce deep venous thrombosis, which leg is at higher risk of developing the blood clots? The one that didn't have surgery or the one that had surgery? Right, the one that had surgery. So the foot compression product is on the wrong foot. It should be on the opposite foot. If you believe that he's at risk of pressure injury on the heel, I agree with you, but not in his non-operative leg. Would you agree with me that it's the other leg that he doesn't move because of pain from the surgery? So elevating the heel is a great idea. It's just on the wrong leg. Okay, so if you believe that this elastic stocking is able to reduce edema, which leg is more likely to be edematous? Yep, you're right again, the operative leg. We've talked a bit about medical device pressure injury, haven't we? Well, these elastic stockings are a medical device, and therefore they shouldn't be rolled down beneath the knee. The patient rolled them down because they were too tight in the thigh. Now what they've become is a tourniquet behind his knee. And finally, if you're aware of the risk of surgical site infection, you probably realize that the dressing should not be taped in such a loose manner that it comes off. And the better dressings today for surgical sites are ones that are occlusive and flexible and stay on the patient's leg. Good job, you guys. I bet you got a number of those. So what can we do for moisture? Well, just to help you understand the importance of it, when patients are incontinent of urine or stool, the skin actually absorbs the water of the urine and the water of the stool, and then the skin becomes boggy and starts to break down. And so it increases the risk of injury from pressure because the skin is not anatomically the way it used to be. So if this patient is normally toileted and taken to the bathroom every couple of hours or goes to the bathroom, get the patient to the bathroom. Either put a commode by the bedside or ambulate the patient to the bathroom so that they don't have to have an episode of incontinence. They're already in the bathroom. So if you're doing hourly rounds, make one of the hours taking the patient to the bathroom or placing the urinal. If the patient is incontinent and it's more unpredictable, use a high absorbency pad or one that wicks away moisture rather than the plastic backed pads, but don't use 6 or 8 of them. Keep them down to 2 at a time. They don't do any additional good when they're stacked on under the patient. And in fact, if the patient's on a support surface, they're actually going to work against the support surface. Use briefs for the incontinent patient, but only when they're out of bed. Don't use them in bed. And if you have a patient who gets up and down often, open up the brief and let the body get some air in the perineum when they're at bed rest. If they've been incontinent, I want you to follow this general approach, and that is to cleanse the skin. Use a soft washcloth. Do not use soap. Use a skin cleanser designed for perineal care. Don't scrub the skin to clean it. The skin of the perineum and buttocks, particularly in incontinent patients, is already very raw and very fragile. So don't scrub the skin. Pat it to dry it. You don't have to get all the moisture off as long as what you're leaving behind is water. Don't rub it. And then put a barrier cream on the patient, particularly one that has dimethicone or zinc oxide or petrolatum. Those become a barrier, so the next incontinence attack doesn't reach the skin. It actually comes off. And if a patient has frank diarrhea, continuously watery stool, and they're bedridden, ask your nurse, your charge nurse, your instructor about using a fecal containment system for them. Obviously not going to be needed in an ambulatory patient, but needed in a bedridden patient. So interventions for the inactive patient. Now remember from Braden, inactivity is the ability to be up and out of bed. And so can this patient move on their own from bed to chair? Do we need to move them? Or are they consistently locomoting around your facility in a wheelchair? So if they're getting up out of bed into a bedside chair, put a chair cushion in the chair for them. I gave you a couple pictures of some good ones. Instruct the patient to change their position in the chair. Stand up at the chair edge if possible. Now, if this is a fall risk patient, you're going to have to help them stand. If you're transferring the patient with a lift, you're going to want to leave the sling under them while seated. But realize that that sling, particularly if it's canvas, is working against you as far as pressure relief because it doesn't have any stretch in it. So if you're sitting on a sling on top of one of these cushions, you're not getting any benefit from that. So you're going to have to reposition more often. Try to limit the hours a person sits in a chair, particularly if they don't move, to 2 hours at a time. And when they go back to bed, turn them on their side. Tell the patient, you've been on your butt for a long time today. Let's get you on your side to get some pressure relief. For patients who use a wheelchair for mobility, so these are patients that are paralyzed, patients with chronic degenerative disease like muscular dystrophy, multiple sclerosis, use a chair cushion. You're going to ask physical therapy for suggestions on which one. It's not going to be the two that I have on the slide. Those patients, because they have very restricted mobility, should be changing their position every 15 minutes. And you should go in and make sure they're sitting correctly. They're sitting up, they're not leaning to one side, and that they're clean and dry every hour. Moving to mobility. So this is, how does the patient move in the bed? Do they move independently or do they move with help? So you need to educate patients who can move themselves in bed but don't move often. So this is a patient who can do it. You need to educate them on the benefits of moving. There's lots of benefits. You breathe better. You have better blood flow. You get some work in your muscles. Of course, your skin gets a chance to reperfuse. And then I want you to confirm that the patient is actually moving in bed. So I don't want you to write in the chart, patient moves himself, when clearly he does not or cannot. So for patients who cannot move or do not move, upgrade the mattress to what we've already talked about. Put a protective multi-layer foam dressing on the sacrum because these are patients that for whatever reason you can't get them off. Turn the patient every 2 to 3 hours into the 30-degree lateral position as you can see on the drawing, and then hold the position in place with wedges or pillows. Don't put the wedges behind the buttocks. You can see in the drawing the buttocks are free. And I want you to run your hand under the patient's hip to make sure that you've got the sacrum off of the bed. You can see in the drawing that the buttocks are actually on the bed and the sacrum is up in the air. We want to get that sacrum off of the bed. Turn the patient's head to the side when they are turned, and then separate the knees and ankles with pillows or blankets to make sure that you don't get pressure injuries between those bony prominences. Of course, we have to turn bariatric patients too. So step one is to make sure that they're in a bed wide enough that they can be turned. Those are called bariatric beds. Going to need a lot of help to turn the patient. You're going to need to use some ergonomically designed lift aids or transfer sheets to make sure that you can mechanically do it without injuring yourself. They do make bariatric wedges that will hold the patient in place. And then when they're on their side, be sure you're supporting large folds of skin like the abdomen with pillows to make sure the patient's comfortable. And when you're moving them, it's really a good time to use moisture wicking fabric in the skin folds. Bed linens like pillowcases and washcloths and towels do not wick, and all they do is leave the moisture of sweat back in the skin folds. So be looking for a moisture wicking fabric for that patient. So when we move into interventions for the malnourished patient, I need to remind you that oral intake in patients who are hospitalized is really quite low. And it's low for a number of reasons. It's low because we repeatedly make somebody NPO to do various tests. It's low because of pain. It's low because of what they've been told about their disease. It's any number of things. On top of that, most of us eat in a social relationship. It's hard to eat by yourself. And many of the patients in the hospital are all alone trying to eat. So don't be surprised that you're not looking at malnutrition fairly often in hospitalized patients. To some degree, that's also true in institutionalized patients anywhere, is that the diet that they can be offered or the ability to socialize is limited. We rely on calorie counts to give us pretty clear data on the actual intake of the patient, and you should look at that as a piece of evidence in your nursing diagnoses. So some nursing interventions. We're going to be weighing the patient daily in the hospital, probably weekly in long-term care. Occasionally it's more often than that. But important from our perspective is to analyze the trends. Is that weight going down, or is it going up, or is it staying the same? Be sure the mouth is clean enough to eat, that the medications you've given don't leave a residue in the mouth or an aftertaste. And then work with the nutritional services people. They have great ideas on how to improve intake, offer different choices in foods that the patient may not realize they have. So if you're working with a patient who normally eats by mouth, assess the condition of their mouth, their teeth, and their gums, and make sure that they don't have problems such as stomatitis or difficulty chewing the type of food that they're being given on their trays. Look at the usual type of food that they eat. Maybe their culture doesn't eat the foods that you're serving in the institution. And if that's the case, you may want to ask the family to bring in some of those foods if it's possible. It isn't always acceptable within the diet restrictions that they have, but at times the diet can be liberalized to make it possible. Try to give your oral medications with supplements if they're ordered. The use of water to help patients get medications down is great, but you can do better than that by giving the patient their oral meds with the supplements that are ordered anyway, and you kind of kill two birds with one stone. Be aware that mechanically altered diets, such as pureed diets, can often be eaten without additional fluids, and so the patient may lack oral intake of fluid and therefore have a risk of dehydration. Now, for the patient that is tube fed, be sure that you're thinking about the impact of the medications when the tube feeding has to be held. So you may end up compounding the problem in that you're holding the tube feeding to give 7 o'clock medications, and then you're shutting the tube feeding off in order for physical therapy to work with the patient at 9 o'clock, and then they have tests at 11 o'clock. And so be careful that you don't stack hour upon hour upon hour of turning the tube feeding off. And so think ahead about getting the schedule different enough so that you can sort of kill two birds with one stone. You can hold the tube feeding and then give the meds all at the same time that the patient's going through PT. One of the things that's been started, particularly in long-term care, is that orders for tube feeding, instead of being written over a 24-hour period, are written for 20 hours. So it's the same volume of tube feeding, it's just given over 20 hours. And that gives you 4 hours of time during during a day in which the patient can do things, get medications, go to physical therapy, and not alter the volume of tube feeding that they're getting. When we look at the last subscale of Braden, which is on friction and shear, we need to be reminded a little bit that friction and shear forces are those forces applied to the skin and soft tissue when a patient slides down in bed, is boosted back up in bed, or when the patient rubs their heels into the bed. So the agitated patient or the spastic patient. Sometimes confused patients will do that, particularly when they're in pain. So some nursing interventions are really focused on stopping the sliding. So if we can keep the head of the bed below 30 degrees head of bed elevation, it's helpful because the patient just doesn't slide as much. Now, there are patients that cannot have that, and so we obviously can't write a nursing order for this if it's unsafe for the patient. So those are patients who are tube fed, patients on ventilators, patients with head injuries, patients with difficulty breathing generally can't lay their head that flat. And so generally we keep the head of the bed at 30 or sometimes even as high as 45. So if the patient has to have the head of the bed up, one of the things you can do to stop them from sliding is flex the knee gatch in the bed so that when they slide down, they don't slide all the way to the foot of the bed. And of course, if you can encourage the patient to sleep flat at night, it changes the pressure from predominantly on their sacrum to other parts of the body. So presuming that gravity is still pulling your patient down to the foot of the bed, you have to move the patient back up a couple of ways. One is to use sheets that are designed to facilitate movement of the patient or lifting devices that are designed to help you ergonomically get that patient back up to the head of the bed. If the patient can help themselves, then have the patient use a trapeze. You're going to have to work usually with physical therapy to get the trapeze put on the bed, but put a trapeze on the bed, and that way the patient can lift their arms and head and shoulders off of the bed, sometimes push off the foot of the bed with their feet and help move themselves back up to the head of the bed. And there are multi-layer foam dressings that you can apply to the sacrum and heels that will help reduce the effect of friction and shear. Hopefully you remember at the beginning of this presentation, I said there are some things that affect pressure injury risk that the Braden score does not address, and one of those is perfusion. I don't know if you remember, I didn't spend a lot of time on it talking about a change in the Braden scale for pediatrics, which included this idea of tissue oxygen and tissue perfusion. There hasn't been a revision of the Braden scale for adults to pick this up, but we do know that perfusion is a risk factor for pressure injury, and it really affects the tolerance of tissue for pressure. So who are the high-risk patients? Those are patients that are critically ill. They're on drugs called vasopressors, which compress the vessels, particularly in the extremities, to try to shunt blood back up to the heart and brain. And when they do that, the extremities can develop pressure injuries pretty quickly. Patients with advanced peripheral arterial disease, so those are people that you see that have very thick nails, very thin skin on the feet. The legs are generally hairless. You have a lot of trouble finding a pedal pulse in those patients. And then patients with diabetes, and particularly patients with diabetic neuropathy. Those are the high-risk patients for problems with blood flow. So what do we do for them? You need to protect the heels by either elevating them off of the bed, the way we talked about a few slides back, using pillows or boots, or if the patient doesn't tolerate either one of those because of poor blood flow, you can use those prophylactic dressings on the heels to protect them. I do think it's important to keep the legs warm, so you can use blankets, you can use clothing, you can use fleece boots. Whatever helps to keep the skin warm, because you want to try to improve blood flow as much as you can. When the patient ambulates, be sure they ambulate with something on their feet so they don't injure their feet. The reason I'm saying that is it's dang near impossible to get wounds to heal in patients who have limited blood flow. And then if they're ambulating, check to make sure that their shoes are safe for them to wear, that they don't have pieces of loose leather openings in the stitches of the shoe, and that the sole of the shoe is still good, so that they're not injuring their own foot while they're ambulating. Well, let's go back to this 92-year-old lady that we admitted a while ago with a fractured hip, and she came into the facility in Buck's traction, which is a skin traction system, and she has pain and spasms anytime she's moved, so moving her is going to be difficult. Confused at times, obviously only oriented to herself. She's 5 foot tall and weighs only 85 pounds. So her risk of pressure injury was very high using the Braden scale. What can you do to reduce her risk? I'm going to stop right now and ask you to put this on pause while you look back at the risk factors that identified her risk that we've talked about already, and then go back through those same sets of interventions and see what you can come up with to individualize a plan of care for this lady. Well, let's go back to this little lady who got admitted from the nursing home with a fractured hip today. What is true about her? So she certainly has a sensory problem because she's not able to move herself in bed. So I need you to be asking about pain in her heel or leg from that boot. She's got a medical device on, and that medical device tends to pull the heel down in bed. If she develops pain in her heel, it can be a sign of early pressure injury. And so if that's the case, you'd want to notify the orthopedic surgeon who put her in the traction to see if there'd be a way to reposition that traction system so that you could slide a pillow underneath it and get the heel off of the bed. You also need to, because she's not able to move and not able to sense real well that she needs to move, you need to put her on an alternating pressure overlay on her bed. That should have been done before she came in, right? She's inactive and immobile. Fortunately for us, a prophylactic dressing was placed on the sacrum in the emergency room. I didn't tell you that. I wanted to see if you could figure that out on your own, because now, what are you going to do with it now? How would you get it on her now? You can't turn her very easily, and they had to turn her to get her out of her clothing in order to examine her hip. So they had to do what they did. It will be very hard for you to turn her now and put her in the dressing because she can't be turned while she's in traction. You need to make her move her other leg and help her move her arms and lift her head and shoulders off the bed, but you really can't move the fractured leg. So in order to do any kind of movement, you need to manage her pain. From a moisture perspective, she's got an indwelling catheter, but at her age, she certainly has problems with dry skin, so I would moisturize her skin. Then nutritionally, I don't know why she's underweight. I don't know anything about her at this point, but I would check to make sure that while we're trying to feed her orally, that she has adequate teeth, her gums are in good shape, her tongue is in good shape, to make sure that she's able to consume the diet. If she's not, work with nutritional services, because our goal is to get her oral intake up. She's got to heal a fractured bone, and that's going to take a lot of protein, calcium, calories in order to get it to heal. For friction and shear, I want to keep her head of bed as low as she can tolerate it, because I want to reduce the tendency of those weights to pull her down in bed. It would be helpful to put a trapeze on her bed to help her reposition herself. Now, hopefully, you got all the same ones I did. Maybe you got some other ones. You can talk about it with your instructor and see if what you came up with is even better than what I have. Hopefully, that's the case. You may have been thinking about the fact that a lot of the interventions that I listed on the slides based on the Braden subscales could be done by somebody that's not a licensed nurse. And you're absolutely right. There's a lot of components of pressure injury prevention that can and are done by other people that you delegate that to. And you can see the list, it's long. Those are folks that can look at the skin when they provide care. They can float the heels. They can clean up the patient after incontinence and make sure that the skin is re-moisturized. They can turn and reposition, boost the patient up, take some of the medical devices off, not all of them. Some of them are very medically driven, and so the nurse would need to be involved, but certainly stockings and sequential devices could come off by assistive personnel. Assist the patient to eat, fed by mouth, provide any oral supplements that the patient should get, help them to stay safe in the chair by repositioning them if they're slouching, or have them march in place if they can do that, and then reduce friction and shear by keeping the head of the bed down. So the nurse's role is to develop that individualized care plan so that we all know, all the members of the team know what the care is that's needed to be provided. But then the nurse also remains responsible for the delegated interventions. So the question is for you is, how are you going to verify that the care plan is being followed? Are there things here that you could check up on? Of course there are. You're going to do a formal skin assessment once a shift, and so you would be able to see things that have changed. You should instruct the staff to come and get you anytime they see anything abnormal. If you want to verify the patient's been turned and repositioned, go in, make rounds hourly, and have the nurse's aide make rounds on the other hour, and you'll be able to see if this bedridden patient is being turned as they should be. You'll be able to see if they're slouched in the chair, and you'll be able to see the empty cans or bottles of oral supplements in the trash. Don't delegate it and not follow up on it. Be sure that you have a plan in place for how you can watch that care being done. You may need to model the care for the nurse's aide. Perhaps she's afraid to touch a patient in skin traction, has never done that before. So how can I show you how to do what you need to do? Because I need you to do it correctly when I'm not there. So plan to be a role model of how this work is done, and then plan to follow up that it's being done correctly. There are some hospitals that actually have used a group of people called a turning team. And the purpose of that team is simply to provide one of these interventions, which is to turn the patient either every 2 hours or every 3 hours, but that's all they do. That's not the whole story, as you can see, of all the other interventions. So again, if you have a turning team, that's great. That doesn't mean you're eliminated from being responsible for that care. Well, thank you for spending some time with me thinking and talking about pressure injury prevention. Pressure injuries are a very serious problem that occur in a great number of patients in all settings around the world. Our role as nurses is extremely important. We are the lead on this condition. There's really nobody else but the nurses who take as much responsibility for preventing pressure injuries. So know your role. Your role is to identify where the risk is coming from, immobility, inactivity, incontinence. Where is that risk coming from? And then develop an individualized plan of care that will reduce those areas of risk. Obviously, if this patient is ambulatory and malnourished, they don't need to be on a turning program. So make that care plan individual to that patient's level of risk, and keep our patient's skin intact. Thank you very much. This has been Joyce Black, part of the National Pressure Injury Advisory Panel, and I appreciate all of your time and attention.